Good evening, everybody. Good evening. Thank you so much for this warm welcome. Respected dignities, ladies and gentlemen, I'm really deeply grateful to be here, and I would like to share my clinical experiences and research results done at the Institute of Sexology, which is part of the University Clinic of Berlin. Can you hear me? Okay. And the clinic is called Charité. It is supposed to be the biggest university clinic in Europe. And this is the building I'm working in. I'm working in the same office as Robert Koch did, who once discovered the infectious agent of tuberculosis. This was in the year 1882. So there is a huge medical history in Berlin, and this is true for sexology as well, because this discipline was founded once in Berlin 110 years ago. And I'm working there as a physician since 20 years now in this institute, and since 30 years in the field of sexology. And in the outpatient, this is not the right, excuse me, I have to start again here. So in the outpatient clinic of the institute, we are dealing with the whole spectrum of sexual disorders. As you can see here, disorders of sexual function, which are very common, and it's a long-term consequence for victims. I will refer to this later on. Disorders of sexual development, and then the gender dysphoria is a huge area. Disorders of sexual reproduction, but for today, for the evening, I will refer to those both. Disorders of sexual preference, another term would be paraphilias, and disorders of sexual behavior. And you will see that we can differentiate those disorders very well. So there is one basic concept of sexuality which appears to all these disorders, and it's very important to understand this concept. And you will see it's important for our understanding of sexual preference disorders as well. And this concept means that there are three core dimensions within sexuality. One is the dimension of desire, which is very well known, and the importance of sexuality and all its possibilities for increasing desire. Another one is the dimension of reproduction, and the last one, and a very important one, is the dimension of attachment, which is the dimension which is important for the fulfillment of basic psychosocial needs. For example, trust, appreciation, admiration, security. And it's important to know that we are programmed for bonding. It's a biological program in our brain. And this is true from the very beginning of our lives. So we need another person up to the end of our lives for the fulfillment of these psychosocial needs. And this would determine the quality of life, including mental health. This would be acceptance, being appreciated, trust, closeness, warmth, being sheltered, security, and we know if these needs are fulfilled, you are protected before the development of psychic illnesses, psychosomatic illnesses. And we understand better and better why is that so, where does this protection come from? We know more and more about the underlying mechanism. So the neurobiological research tells us that in the brain there are some special set of regions which would react on a person we are really bonded to, we are really in love with, and there is a very interesting first study on this issue. It's done by researchers from London with fast MRI techniques, and what they did is to show mothers just a picture of their child and pictures of acquainted children. And then they showed, this is maternal love. And then they showed them pictures from their partner, beloved partner. Of course you have to evaluate that, is it true? So beloved partners and acquainted men. And then it's very interesting, the results was that independent if they would see their child or their partner, always the same reaction in the brain, a kind of deactivation of those sets of regions in the brain which are responsible for stress, processing stress. These are these regions, you can see the red dots, and these regions are deactivated. So if you are close to a person you are really in love with, then you have a deregulation of stress, and this will protect you for the development of different illnesses. And the same as in this part of the brain, this is a deactivation. This would be the looking at the children, and this would be looking at the partner. This is a prefrontal cortex, and this is an important region for critical thinking. So unfortunately I have to tell you that we know now that these regions could be damaged by child sexual abuse. This is really sad, but our insights are broader and broader concerning this issue. And these are some of the results from a colleague of mine now working together with us. She was first working in the United States, now she is at the Charité in Berlin. And she could show that in women with a history of childhood abuse, a neurotransmitter was very important for bonding, for this bonding process in the brain is reduced. She could find this in the liquor of the women, and then she found in another study that the brains are damaged. That the cortical representation of the genitals in the brain are decreased, so the thickness of these regions are lower. So this should motivate us to think about primary prevention, because we know that we will if we don't prevent child sexual abuse, we will have these long-term effects. And I'm pretty sure that in the next years we will find more and more about these really sad outcomes. And this is what I know as a clinician, because I'm working with victims, as I told you, for example, concerning the disorders of sexual function. So I see women and men coming to us in our outpatient clinic, and what we can find is a history of child sexual abuse. So it can create unfavorable conditions for entering into relationships, for sexual involvement within relationships, possibly for the development of disorders of sexual function, causing consequences for reproduction, because partnership do not last. So I take this very serious because of these neurobiological findings. And according to prevention, primary prevention, we can think how to help potential victims, This is one way to deal with primary prevention, or we can reach out for those ones who are the cause of the offense, so the potential offenders. And I'm now going to tell you a lot of details about the potential offenders. And I will tell you that it's really possible to do primary prevention in this field. What you can see here is data from Germany. And you see that each year the officially known cases are around 15,000, and that only 3,000 offenders would be convicted each year. And then we have population-based studies saying that the cases officially not known are much higher. And we call this Dunkelfeld. Dunkelfeld means literally dark field, so these are the cases not reported to the legal authorities. Approximately 60,000 cases in Germany each year. It's much more than the officially known cases. And we have 75% girls, 25% boys. But we have only 80 million inhabitants. I will refer to this data later, doing some calculations for India, because you have such a huge population. So these are the numbers I know from your Ministry of Women and Child Development. And they say that 20% of the children were subject to severe forms of sexual abuse. That include sexual assault, making the child fondle private parts, making the child exhibit private body parts, being photographed in the nude. And so you see here that you have more boys than girls. You have 57% of those are boys and 42% are girls. I will refer to that later. Maybe we can discuss this important point later. So now this is, if we are going to deal with potential offenders, you know how to reach out for those one who might offend, and it's necessary to know that there are two groups. And one group, and they count for around 40% of the offenders, are pedophilically inclined, which means they are attracted towards the prepubescent body scheme of children. I will tell you more about this, but I can say at this moment it is a program in the brain, and this program is loaded during puberty, as the program for sexual orientation is loaded during puberty. So we will focus later on this group, but now I will tell you there's a bigger group, 60%, non-pedophilically inclined. So they are oriented towards adults, but they are abusing children, and they do this because they use the child as a substitute or a surrogate for relationship with partners of similar age. We have to think about this group, and then we have to think about how are the chances to reach out for them with primary prevention measures. And this is really very difficult. But for this group we can reach out with primary prevention measures, and I can explain you how, and I can tell you the results during the lecture. So now we can differentiate those non-pedophilically inclined offenders in 4 subgroups. Sexually unexperienced adolescents, mentally handicapped perpetrators, offenders with antisocial personality disorder, and one very problematic group, those one coming from generally traumatizing family constellation, which means that the children are traumatized physically, emotionally, and additionally sexually. So there's a multiple traumatization for these children in these families. So these are the recidivism rates, which means which type would reoffend. And you can see these are data from follow-up studies that the pedophilically inclined type would reoffend very often, up to 80% of the cases. 80% would reoffend, but not the non-pedophilic offenders. The recidivism rate is lower. And these are results from follow-up studies, 25 years after the first offense. So this is very important. Now, try to understand these big points. This is the structure, the sexual preference structure manifests on 3 axes, we would say, as clinicians. And you can assess these axes by interviewing the person, and if he is honest, if he is open, if he would like to cooperate, he would tell you what's going on in his fantasies during arousal, during masturbation. And it's one axis will tell you the gender of the preferred partner. Is it a male or a female? Sometimes both genders are in the fantasies, but this is not very often. Then the preferred body developmental age, not the chronological age, the body developmental age. So they can tell you the person I'm seeing is adult, or is early pubescent, or is prepubescent. They can tell you that, according to their fantasies during arousal. And the same concerning the kind and modus of the interaction they would like to have with the preferred partner. So I will show you one example, not to offend you. This is a warning. It's from patients in Berlin, just to give you an understanding what is going on in the brain of an inclined person. So, and to learn that this starts during puberty, and it's really important to see that point. So the patient is now 47, born 1917. And at the age of 12, this is the time puberty starts, he discovered these catalog pictures and found this arousing. We don't know why, but it happens. And we always would say it's fate and not choice. It's not, you don't choose the way you are processing the signals in an arousing way. It happens. So you can see on this picture the 3 axes. You can see it's a boy, which means first axis, gender is male. Then it is a prepubescent body scheme, the second axis. And then he would tell you, if you ask him, what would you like? What kind of interaction would you like? He would tell you, because he is open, because we are working with people who come self-motivated to us. They are cooperative, they are not known to the legal authorities, and they are help-seeking. So they are very open. And he would tell us, it's a boy wearing these woolen tights. I would like to have a contact, I would like to caress a boy and to caress the legs with a woolen tight. So this is a combination of pedophilia and fetishism. And it remained stable since age 12. And you can't do nothing against it. He tried everything. And he's very much suffering, but always, if he's aroused, he will have these pictures in his fantasies. And the problem is, because we will not condemn fantasies, we will not condemn the preference itself. He reached out to motivate 8 to 10-year-old boys to wear woolen tights in order to take pictures and to stroke and caress a boy. So this is a disorder on the behavioral level. And we would take this very serious. We have to differentiate between the fantasy level and the behavioral level. Another example, because it disturbs me most at the time. I mean, I'm working in this field very long, and I have to face the fact that we have a growing part of material in the internet showing child sexual abuse in films, in pictures, and you can see everything. It's really a plague. It's really a huge challenge for our society, and it's an international problem. So I will show you a drawing from 43. It's a patient from ours. He came to us at the age of 43, and this is a drawing as he was 15 years old. So please don't take any pictures from this. This is from a patient of mine. It's just to understand that this boy realizes with 15, you can see, it's a girl, it's a prepubescent body scheme, and his fantasies was to hurt the girl. And you can, unfortunately, you can see in the internet, you can find materials showing exactly this. And he was searching these materials, and then he said, this is wrong behavior, and this is right, this is wrong. And so he came to us for treatment. And he was not known to the legal authorities. So this is a combination of pedophilia and sadism. And he didn't choose this way of fantasizing, but it remained stable during his life. We have to face the fact. And these are the criteria for pedophilia according to the manual of the American Psychiatric Association, and we have quite similar criteria in the classification system of the World Health Organization. So pedophilia is a diagnosis. It's first a diagnosis and not a crime. It's a disorder, and it affects not, to say that in the beginning, it affects not the fully responsibility of the person for his behavior. This is the pedophilic disorder criterion. The individual has acted on these sexual urges, or the sexual urges or fantasies cause marked distress or interpersonal difficulty. And this is what we see in our patients. They are suffering from these fantasies, and they would like to stop them, and we can't stop the fantasies, but we can help them to control their behavior. And we reached out to achieve this goal exactly before they started acting out. So these are the so-called Tanner stages. Tanner has been an pediatrician in the UK, and he developed these stages. You can see this is a prepubescent body scheme, and that if the person, and we are working with these tables, with the patient, we are showing them the tables, and then he would say, only children in this, or boys in this body age, or with this body scheme. And these are the Tanner stages 2 and 3. And there's a new term in sexology, and this is hebephilia. You can very clearly distinguish between pedophilia and hebephilia if the person is really open to you and will tell you what's going on in his fantasies. The term for the attractiveness towards the adult body scheme in sexology is an sexological term, and this would be teleophilia. So this is the theoretical pattern. We have combined types, mixed types, and we have exclusive types, because the DSM would say you have to specify whether the person is exclusively attracted towards children or non-exclusively. That would mean that he is, on the one hand, attracted towards children and on the other hand attracted towards adults. So this is the field. We have the sexual preference, pedophilia, and we have persons in this field who can manage to control their behavior, but they will have the fantasies, and then we have these potential offenders who are feeling the urge to act out. And on this, there is the circle, is the sexual behavior disorder, child sexual abuse, and those are the pedophilically inclined offenders. Dunkelfeld, I told you, is the huge amount of offenses not reported to the legal authorities. So, this is a first idea after what I said concerning the clinical experiences. We know that a pedophilic inclination perseveres, and therefore clinically relevant distress is more likely to be expected than in the surrogate offender type. This is very logical. If you imagine every arousal you have to cope with these fantasies, then it is very clear that their clinically relevant distress can come out. In Germany we did a population-based survey, and we figured out that approximately 1% of the male, only the male population, is fantasizing and aroused by the prepubescent body schemes of children. 1% of the male population. So we tried then to reach out for these pedophilically inclined men. 1% in Germany would mean in absolute numbers 250,000 in Germany. So we get money from the VW Foundation and later from the German government, and we tried to go public with billboards, with TV spots, with advertisements, because we would like to say to the inclined person, we will offer you treatment, not with the goal to delete pedophilia, because we can't do this, but we will help you to control the behavior. And so we came out with billboards like this. And we did a TV spot. Would you like to see the TV spot? It was done by a media agency